Hello friends, welcome to Healthwizac, Medical Concepts Simplified. In this video, we will learn about malaria fever and its management in India. The governing body for malaria control in India include Directorate of National Center for Vector-Borne Disease Control Program working under the Ministry of Health and Family Welfare, who have brainstormed and customized the WHO malaria guidelines as per the regional resistance pattern in India. Malaria is a vector-borne disease caused by one of the Plasmodium species including P. vivax, P. falciparum, P. ovale, P. malaria, and P. knowlesi. It is transmitted in humans primarily through the bite of infected female Anopheles mosquito, but sometimes even blood transfusion or even organ transplantation may even transmit the infection. Malaria can either be complicated or uncomplicated. Uncomplicated malaria have low mortality rates, but recurrent infections and complicated malaria, if not treated timely, have high mortality rates. Transmission of malaria follows sexual phase in mosquitoes and asexual phase in humans, which is as follows. As soon as the female Anopheles mosquito bites the human, it injects sporozoids into the bloodstream, which are carried away to the liver to invade the hepatic parenchymal cells and undergo a phase of asexual reproduction, where each sporozoid gives rise to 10,000 to 30,000 merozoids. These merozoids infect the hepatic cells, which eventually burst, and the merozoids are released into the bloodstream. These merozoids starts invading the RBCs to become trophozoites, where they start multiplying. Infection is manifested when the parasite load reaches approximate 50 per microliter. While in P. vivax and P. ovale infection, a small amount remains dormant in liver up to 1 year period and are called as hypnozoites, which usually causes relapse fever or relapse infection. These trophozoites invade RBCs and initiate intra-erythrocytic phase and are seen as ring form in microscopy. These parasites starts consuming the hemoglobin of RBCs and form schizones. After multiple nuclear divisions, infected RBCs rupture and release merozoids, which then travel into the blood and start invading other RBCs, and the cycle repeats. These parasites alters the RBC membrane properties, making them less deformable and easily rupture, and thus complementing cytoadherence, where the RBCs stick to the capillaries and venules and blocks them, giving rise to rosette formation where the infected RBCs stick to another non-infected RBCs. This blocks the microcirculation and thus giving rise to severe symptoms. During the nuclear division, some of the forms mature differently to form gametocide, and specifically micro and macro gametocide, which start circulating into the blood. As soon as the mosquito bites the human for a blood meal, this gametocide enters into the mosquitoes during the bite, and after multiple division gives rise to ookinete, which invades the midgut of the mosquito to forms oocyte. These oocyte eventually burst and release multiple sporozoids, which start invading the salivary glands of the mosquitoes and re-enters the host, that is humans, during the next bite, thus to complete the cycle. As soon as the parasite invades the host, that is humans, the immune system gets activated, which increases the splenic immunological and filtrative procedures. This starts destroying both infected and even non-infected RBCs, and the release material activates the macrophages and the monocytes to clear up the debris. During this process, cytokines are released, and thus fever is manifested with a temperature ranging more than 104 degree Fahrenheit, which helps in damaging the parasite even more, and the symptoms starts manifesting, where the uncomplicated malaria may present with fever, fatigue, arthralgia, myalgia, headache, nausea, vomiting, low-grade abdomen pain with associated diarrhea, or even chest pain. Now, let's have a look at the diagnostic tools used in malaria. As confirmation of malarial parasite is not a clinical diagnosis and requires clear pathological evidence, thick and thin smear microscopy with Giemsa stain done by an experienced microscopist remains gold standard for diagnosis of malaria. In conditions with low parasite density level, diagnosis can be achieved through RT-PCR method, that is real-time river transcriptase polymerase chain reaction methods. ELISA method screening are also very sensitive in diagnosing malaria and prove helpful in donor screening in blood banks. P. falciparum, histidine-rich protein 2 based rapid diagnostic kits or bivalent RDTs are also available, but they may show positive results several weeks post-infection and are also not quantitative, hence lack sensitivity and specificity, but serve as a great tool where limited resources are available in remote areas. Pathological findings of malaria include following. CBC may show anemia associated with thrombocytopenia with usually normal WBC count, but they may be elevated in case of secondary infection. ESR and CRP may be elevated. Coagulation profile may show derangements in PTINR values and APDT values. LFT may show derangement in liver enzymes. Some patients may even manifest deranged kidney function. X-rays may show pleural effusion, whereas sonography may reveal hepatosplenomegaly. After understanding the diagnostic part of malaria, now let's have a look at the treatment part. The algorithm for treatment of malaria as per National Vector-Borne Disease Control Program is as follows. In region or areas where microscopy is available within 24 hours in all clinically suspected cases of malaria, the first step is to prepare thick and thin smear or slide for microscopy. If microscopy confirms P. vivax positive, then the recommended drug is chloroquine given in a dose of 25 mg per kg body weight in divided doses, along with primaquine in a dose of 0.25 mg per kg body weight for 14 days, where primaquine is given to avoid relapse via hypnozoids. In this regimen, on day 1, 10 mg per kg body weight dose of chloroquine is given orally, followed by 10 mg per kg body weight on day 2, followed by 5 mg per kg body weight on day 3. If microscopy confirms P. falciparum positive, then ACT-based regimen along with primaquine is given, where ACT is artemisinin combination therapy, which contains an artemisinin derivative along with single long-acting antimalarial. The recommended ACT regimen is as follows. In all over India, except northeastern states, the recommended ACT regimen is AS plus SP, which includes artesunate in a dose of 4 mg per kg body weight, along with sulfadoxine in a dose of 25 mg per kg body weight, and pyrimethamine in a dose of 1.25 mg per kg body weight. The dosage is as follows. On day 1, artesunate plus sulfadoxine pyrimethamine single dose is given as per the body weights. On day 2, artesunate is given along with primaquine in a dose of 0.25 mg per kg body weight, and on day 3, single dose of artesunate is given. The recommended ACT regimen in northeastern states include artemether and lumefantrine combination given for 3 days along with primaquine in a dose of 0.75 mg per kg body weight on day 2 for its gameticidal action. In areas where microscopy is not available within 24 hours, in all clinically suspected cases of malaria, a rapid diagnostic test should be performed, in which one amongst the two approaches can be used. In approach 1, P. falciparum based rapid diagnostic kits are used along with preparation of blood smear which is sent to the lab for microscopy. If the rapid diagnostic test is suggestive of P. falciparum positive, then the region-based ACT regimen as discussed earlier is to be started as early as possible. On the other hand, if the rapid diagnostic test for P. falciparum is negative, then in suspected cases of malaria, chloroquine should be started in a dose of 25 mg per kg body weight for 3 days until the microscopy results are awaited. If the microscopy confirms P. vivax, then along with the chloroquine, primaquine is to be given for 14 days. On the other hand, if the microscopy is suggestive of P. falciparum positive, then region-based ACT regimen is to be given in full dose. In approach 2, bivalent rapid diagnostic kits are used. If the bivalent RDTs are positive, then according to the species found, that is P. vivax or P. falciparum, treatment should be given as per the regimen and guidelines suggested. On the other hand, if the bivalent RDTs are negative, then further workup for fever is to be done. In pregnant females with uncomplicated P. vivax malaria, the recommended drug of choice is chloroquine as it is safe to use in all the trimesters. Whereas, in cases of uncomplicated P. falciparum positive, in first trimester, the recommended drug of choice is quinine as ACTs are contraindicated in first trimester. On the other hand, in second and third trimester, ACT regimen can be used and it should be given in the doses as discussed earlier. Friends, while treating malaria, some important points should be noted here are as follows. Monotherapy with oral artemisinin derivatives is banned in India to avoid resistance. Primaquine is contraindicated in infants, pediatrics, and in patients with G6PD deficiency. ACT-based regimen is contraindicated in first trimester of pregnancy and children less than 5 kg weight. All suspected cases of malaria should be started with chloroquine for 3 days, and depending upon the microscopy results available or RDT results available, further modification of treatment and regimen should be done. As far as possible, avoid starting treatment with antimalarials on an empty stomach. If patient vomits within half an hour to 45 minutes after the first dose of antimalarials, then antiemetics like ondansetron or domperidone is to be given first, followed by a repetition of antimalarial dose. All mixed infection, that is suggestive of both P. vivax and P. falciparum, should be treated with full course of ACT regimens as discussed earlier. In cases of ACT failure or resistance noted, that is patient is not improving or having high grade fever within 72 hours post initiation of treatment, he should be shifted to higher center, or the regimen should be shifted to IV quinine along with doxycycline or clindamycin, which will be discussed in section of complicated or severe malaria. High grade fever should be managed with tepid sponging or paracetamol in a dose of 10 to 15 mg per kg body weight. In cases of superadded infection, broad spectrum antibiotic should also be used along with antimalarials. Management of other comorbidities, that is hypertension, diabetes, hypothyroidism and other problems should go hand by hand while treating the primary malarial infections. Finally, let's have a look at the chemoprophylaxis for individuals traveling to malaria endemic areas in India. Under this, 2 regimens are indicated. In short-term regimen, the individual should be started with oral doxycycline in a dose of 100 mg once a day and should be started 2 days before traveling and should be continued for 28 days after leaving the endemic area. While doxycycline is contraindicated in pregnancy and lactation and children less than 8 years, another alternative can be chloroquine. Long-term chemoprophylaxis recommends use of mefloquine in a dose of 5 mg per kg body weight and a maximum dose of 250 mg given once a week and should be started 2 weeks before traveling and should be continued for 4 weeks after leaving the endemic area. In case of pregnant females, the recommended drug for chemoprophylaxis is chloroquine, which should be started from second trimester, and the recommended dose is 10 mg per kg body weight loading dose before initiation of traveling, followed by 5 mg per kg weekly dose, which should be continued till 1 month after leaving the endemic area. So friends, this brings us to the end of this topic. Hope you find this information valuable and applicable in your clinical practice. Please do like and share this video and hit the bell icon for latest updates. And for more such informational videos on medical topics, please subscribe to YouTube channel Healthwizac, Medical Concepts Simplified. Thank you.